We're going to move on now to Dr Hui Ling from the University of Hong Kong, who is going to talk to us today about some of the work that her and her group have been doing, looking at environmental sampling for flu and coronavirus. Dr. Yen, all yours.
Thank you, Professor Grantham. Thank you for the kind invitation to join the workshop. So I'm a virologist, actually working previously with influenza virus, and starting from last year, moving to work with SARS coronavirus 2. And we have some collaboration with Prince of Wales Hospital, particularly on the environmental sampling and then also a seroepidemiology. So I will be presenting some of the data today. Let me just share my screen first. Can you see the screen?
Yes.
Okay, thank you. So as mentioned, so we've been working on flu for quite some time, and starting from last year to work with SARS coronavirus 2. So today my talk will be divided in two parts. So the first part will be assessing the risks of exposure for the healthcare workers at the Prince of Wales Hospital. There will be two studies that I will present today. So we've been collecting air and environmental samples at the A&E department, starting from April 2020 till March 2021. And then we have recently also performed a cross-sectional seroepidemiology for staff working at the Prince of Wales Hospital. In the second part, I will be shifting to influenza, just to contrast the differences. So the first part is sampling at the healthcare facilities, and where there will be patients and then will be risk of exposure. But in the second part, I would like to shift it to assess the risk of exposure at the public location. So this is a study that we've done doing air sampling at the university campus. So for SARS coronavirus 2 infections, we know that about 30% of the individuals, they've never developed symptoms. So 70% of them, they will show symptoms, but majority of them will be showing very mild symptoms, about 81% of them. So according to most recent CDC estimation, they calculated that about 59% of all SARS coronavirus 2 transmission will come from either the pre-symptomatic patients or the asymptomatic patients. So looking at this clinical iceberg, I'm sure everybody's familiar with this, you can see how different level of COVID-19 tests is going to affect the number of people that you can identify in the total population that is actually infected. So if you have a very stringent test that's being done at very high frequency, you will be able to catch majority of those who perhaps showing symptoms, right? So you will see that on the left-hand side, the blue area with a very stringent test that's being performed. But in another country or city, if there's not so much test being done, then you will be only monitoring a small fraction of the total infected individuals. So of course, we know that those individuals, they will seek healthcare assistance. So for those that were tested positive, they will be sent to isolation ward. But those who are not tested positive, then they will be sent to other units, or they may come to A&E departments because of other reasons, for example. So this is also highlighted in a large-scale seroepidemiology that was done in Denmark. So in this study, it was an observational cohort study. They've reported that in a week in April 2020, the seropositive rate among the healthcare workers was about 4% in 28,000 people who were being followed up. So this is mainly done with IgG or IgM detection against the spike protein. And this is higher, significantly higher compared to the blood donors, which is reflecting the infection in the general population, which is about 3%, which is understandable. But when they compare people, healthcare workers who have no they are not frontline workers, or compared to those who are frontline workers, which is shown in the pink color, or those who actually have direct contact with COVID-19 patients, which is shown in green color, you will see that the risk or the seroprevalence was higher for those frontline health workers, and even higher for those who are working in the dedicated COVID-19 wards. And another analysis was showing that people or healthcare workers who reported regular patient contact was more likely to be seropositive than those who reported no patient contact. So apparently, the contact frequency with the patient is very important. So we started to work with Professor Granham and his team because of the hypothesis that the A&E department may be under a higher risk to be in contact with the incoming patients. So sampling was done starting from April 2020 till March 2021. We perform either weekly or every other week sampling. We collected samples from services and also from the air. We divided the A&E department into 3 zones. So the first zone is a patient area. As you can see here, this is the waiting area for the patient, where we will swap the registration counter, the chairs at the waiting area, the door handles at the washrooms, the washroom soap dispenser or alcohol gel dispenser. The second area is the patient healthcare worker overlapped area, so where they will have interactions. So we will sample the triage desk or the plastic barrier that's usually separating, preventing spread by aerosols. And then the floor near the triage desk, some walls near the trauma room, countertop of the nurse station, for example. And the third area is the healthcare worker specific area. So there will be no patient coming into this area. And then the services will be touched mainly by the healthcare workers. So that will be the keyboards at the nurse station, phone, intercom, and also at the changing room of the healthcare workers. In addition to that, we've used this device, which is a bioaerosol sampler that will collect air. So this collects 3.5 liter air per minute, and we perform a 30-minute air sampling. And this particular device has the capacity to fractionate airborne particles into 3 size fractions: larger than 4 micron, 1 to 4 micron, and less than 1 micron. And then we will do separate RT-PCR to detect if there's any virus-laden particles in those size fractions. So from April 2020 to March 2021, we've collected 2,216 surface swabs, and only 3 positive were detected. So those you can see here, they were detected in April 2020, September 2020, and December 2020. That's kind of coinciding with the second wave, the tail of the second wave, and the tail of the third wave, and the peak of the 4th wave. And then also in regards of the, that's the timing of the positive samples. And then in regards of the area, you can see that they were either located in the patient healthcare worker overlapped area or in the patient area alone. So suggesting that the patients is likely the ones that's introducing those RNA into the environment. As for the CT values, which reflects the copy numbers on the surfaces, you can see that those are all at very low positive, low copy numbers on this surface area that we have sampled. So we also perform a cross-sectional seroepidemiology. So this is still ongoing. We have already collected the first blood draw in January 2021. And the second blood draw is ongoing, and we are finishing at the end of this month. So the data I'm presenting to you today is the serology test done with the January blood samples. So the eligible participants will be anyone who works at the Prince of Wales hospitals. They can be doctors, nurses, or cleaning staff, or healthcare assistants, or even canteen staff can join. So participants are being asked to fill a pre-sampling questionnaire for the information on their occupation, their contact frequency with COVID-19 patients, and the PPE they are usually using. And we use the surrogate virus neutralization test to detect any presence of anti-receptor binding domain neutralizing antibodies. And any borderline or positive samples will be validated using the plaque reduction neutralization tests in the BSL-3 facility using the wild type SARS coronavirus. And from here, you can see that we have a good coverage of different occupations. The majority of them are healthcare assistants. We have also a good representative for cleaning staff, and we have also a good number of nurses participated in the study. And in regards of the working department, we have medicine, A&E, and also pediatric and adolescent medicine being the highest. And apart from that, we have also cleaning staff, which accounts about 20% of the total participants. So just a brief introduction of the assay itself. So this assay is an ELISA-based assay. So on the plate, you will see the ACE2 receptor being coated. And then there is a receptor binding domain that's conjugated with HRP. So if there is no antibody, this HRP conjugated RBD is going to bind to the ACE2 receptor and give a signal, right? But if in the presence of neutralizing antibody, this will block the binding of the RBD to the ACE2 receptor, and then therefore you will see a reduction in the signal. So among the participants, we have detected 2 samples that was showing moderate or borderline readings by the surrogate virus neutralization test. Therefore, those samples were further tested in a BSL-3 lab using SARS coronavirus 2, as well as the 2003 SARS coronavirus as well. So both samples were test negative for the SARS coronavirus 2. And then one of the sample was tested positive for the SARS coronavirus in 2003. So overall, the seropositive rate of the healthcare workers at the Prince of Wales Hospital was 0%. So 0 out of 377 samples that we have collected in January 2021. So a brief summary for this part. So from April 2020 to March 2021, SARS coronavirus 2 viral RNA has been detected at low frequency from services sample at the A&E department. There was no air sample tested positive. So the positive surface swabs were sampled from the patient area and the patient healthcare worker interface, suggesting the risk was introduced by the incoming patients. These positive samples were detected at the end of the 2nd wave, the end of the 3rd wave, and at the peak of the 4th wave in Hong Kong. The cross-sectional seroepidemiology study performed in January detected no antibody response against SARS-2 among the 377 staff at Prince of Wales Hospital. Overall, the results suggest that the risk of exposure of healthcare workers to SARS-2 is very low, possibly due to the low-level transmission in the community in Hong Kong. So this also echoes with Professor Granham's previous talk that he mentioned that Hong Kong actually is doing very well in regards to response to COVID-19. And I think this data does prove that. And the second part is moving on to detecting influenza virus or other respiratory viruses in a more general public location. So this is a study that we have done in a university campus. From 2016 October to June 2018, we've been collecting air samples at different locations within a university campus. That includes the lecture halls, university health care services, canteens, shuttle buses, using the same bioaerosol sampler that I mentioned earlier. In addition to collecting air samples, we also recorded the environmental factors that includes indoor-outdoor temperature, relative humidity, indoor CO2 concentration as a reflection for ventilation. In addition to that, we have also recorded ecological factors that includes the number of occupants on site. So you can see that we didn't perform sampling in summer vacation in 2017, but you can see that among the various different locations that we perform sampling, that includes 2 canteen, 2 lecture halls, shuttle bus, and the university health care services. The indoor temperature, absolute humidity or relative humidity were quite comparable at those locations. However, some of the other parameters were quite different. That includes the numbers of occupants on site. So you can see particularly one canteen was very popular. So we usually sample the air at around lunchtime. So that's the peak hour for that canteen. So that location has a lot of people during that sampling period. One of the canteen has a relatively higher CO2 concentration. And also the shuttle bus seems to have a higher CO2 concentration as well. So overall, we have detected influenza A virus, influenza B virus, and rhinovirus, as well as RSV during this study period. So influenza virus was detected at higher frequency compared to others. Particularly influenza A was detected at around 16.9%. Influenza B was about 4.5%. So RSV was at 2.2%. Rhinovirus was at 2.2%. RSV was at 0.4%. And we also performed multivariable logistic regression, trying to understand what are the factors associated with the detection of influenza virus RNA in air. So the best fitted model shows that 2 parameters actually positively correlated with the detection. So that's increased crowdiness and also increased indoor temperature. So these 2 factors will actually be positively correlated with detection of influenza virus in air. Other parameters, including humidity, either absolute humidity or relative humidity or absolute humidity difference between indoor and outdoor, they were not significant. Another interesting thing we noted is that there's a difference between the size and particle size, where the influenza virus RNA were detected in different timing. So if you remember that our device was capable of fractionate airborne particles into 3 size fractions, larger than 4, 1 to 4, or less than 1 micron. But interestingly, in springtime, if you look at the diagram here, you will see that majority of the positive samples were particles larger than 4 micron. But in the autumn, majority of the positive ones would actually be less than 1 micron. So this is something we are still trying to understand what is affecting this. Another thing we try to analyze is trying to see the detection of the virus in air at the university. How does that correlate with the detection of respiratory viruses in Hong Kong? So we tried to collect data from CHP Hong Kong. So they reported weekly influenza positive rate detected from respiratory specimens that were collected from symptomatic patients in Hong Kong community. So this is shown in the bar chart. You can see all the bars. So that shows the frequency of the community cases. And the line shows the detection frequency of the viruses in air that we perform in the university campus. And we noted that during this study period, there were 2 epidemics. So one is caused by the AH3N2 in summer of 2017. You can see here there's a peak of the green bars. And then in winter of 2017 and 2018, there was an epidemic for influenza B, as shown here with the peak with the blue bars. And interestingly, that we can detect H3 viral RNA from the air at the university campus before the epidemic in the community, but not after the epidemic. And similar things was also observed for influenza B. We can detect the virus in air before the epidemic in the community, but not afterwards. So this suggests that the air sampling may be used as a tool for early surveillance or early detection signals. So summary for part 2, we were able to detect viral RNA for flu, RSV, and rhinoviruses in air at a sample from a university campus. And we found that cloudiness and increased indoor air temperature were associated with detection of influenza airborne particles. And interestingly, higher copies of influenza viral genome were detected from airborne particles larger than 4 micron in spring and less than 1 micron in autumn. We found that the influenza A, H3, and flu B that caused epidemics during the study period were detected in air prior to observing increased influenza activities in the community. This study, unfortunately, is limited by the specific demographic features of the study population and their behavior, which may limit the extrapolation of the results to other public locations. And air sampling as a surveillance tool for monitoring influenza activity at public locations may provide an early detection signal for on influenza viruses that circulate in the community. So finally, I'd like to acknowledge the funding. So the A&E study was funded by the HMRF Commission study. The serology study was supported by theme-based research. And the study was also supported by the funding by NIH. And particularly the hard work was done by the staff and the students. I like to highlight it here. Ms. Louise Yon, MPhil students, was in charge of the A&E study and the serology study at the Prince of Wales Hospital. And Ms. Claire Xie was the one who performed the university campus study air sampling. And particularly, I'd like to thank the collaboration with Professor Granham and Dr. Hui Ling from the A&E department. So they've been providing tremendous support on this, and without them, we are not able to perform those studies. And from Hong Kong U, I also like to acknowledge my colleagues, Professor Malik Paris, Professor Ben Cowling, Dr. Avery Lau, and Dr. Nancy Learn, as well as Professor Yugo Lee from Mechanical Engineering. So finally, the NIH samplers were provided by Professor Dr. William Lindsay at the NIH CDC USA. So thank you for your attention. I'd be happy to take some questions.
Dr. Yen, thank you very much indeed. That was excellent. And if you don't mind, we'll keep the questions till the round table towards the end. But thank you. That was superb.